a pleasure to be here. It's a beautiful spot, and I'd like to thank Dr. Martins for inviting me. So, I think that the whole controversy regarding hormone replacement therapy in breast cancer has gone full circle from when the first results of the WHI were actually published in approximately 2002. And so what I hope to achieve today is actually to provide some subsequent data that we have. I think that our understanding of breast cancer has really expanded significantly since 2002. And hopefully with some of the other studies that have been completed and with some of the seminal research that's been done, perhaps we can start to understand the findings of the WHI. First of all, I have no financial disclosures to make. But I think to begin and to understand that we have to go back to the beginning. And HERS, or the Heart and Estrogen Progestin Replacement Study, was actually the study that predated the WHI. This was a really interesting study. It looked at the use of hormone replacement therapy in women who had known coronary artery disease or known risk factors. And it was done to determine whether or not estrogen and progesterone replacement therapy could alter or change cardiovascular risk factors. And what they found was that the patients who actually used estrogen and progesterone compared to placebo did have more cardiac events in the first year after initiating therapy. But by years 4 and 5, while still on therapy, the amount or the numbers of events had decreased. They found that the EP group had more venous thromboembolic events, which we would expect to find, because that's really been shown in all studies that have been done, and an increased risk of gallbladder disease. But interestingly enough, they found no difference in terms of hip fracture, cancer, or total mortality, perhaps because of their population. Perhaps they were more of an overweight group of women. But what I think was probably one of the most interesting findings of the HERS study was that despite the fact that this was a group of women who were at risk for coronary artery disease, their cardiovascular issues and problems were undertreated. Most women were taking aspirin, as would be expected, but only a third of patients were actually treated with beta blockers, and 50% of patients who met criteria for statin use were being treated with statin. And so we find that the women who were at greatest risk for cardiac disease were least likely to be treated with aspirin or lipid-lowering medications. And it really points to the fact that perhaps, despite the fact that these women did have increased risk factors, we're not appropriately treating them. Risk factors are pretty much what you would expect for coronary artery disease: lack of exercise, diabetes, angina, congestive heart failure, more than one prior MI, hypertension, elevated LDL levels, lower HDL levels. And the two findings that can really be attributed to HERS was the fact that lipoprotein A levels were considered a risk factor for patients in the placebo group. Those elevated levels were actually associated with an increased risk of coronary artery disease and cardiac events, where they did not see the similar findings in the HRT group. And that's because we know that HRT actually does lower lipoprotein A levels. And so that was a protective effect. And this was actually one of the first studies that actually showed an association between creatinine clearance and the risk of coronary artery disease. Well, I'm not going to really spend much time on the WHI trial. I think we all know it. It was a parallel trial. It was a randomized, double-blinded, placebo-controlled trial looking at the use of conjugated equine estrogen alone or in combination with medroxyprogesterone acetate. So the patients who had previously undergone hysterectomy did not receive the progestational agent. And it was really initiated to determine whether HRT reduces cardiovascular events in postmenopausal women. Well, after 5.2 years, the study was halted because of the excess risk that was found. And the estrogen-only arm remained open, but did close 8 months early. When we look at the population that actually was enrolled on the WHI, we find that women with a history of coronary artery disease were not excluded. And in fact, 400 women that were placed on WHI would have met criteria for HERS. So we have a somewhat, now you could say, well, it's only 400 patients out of thousands, but still there was a group of women who were going to be at higher risk for subsequent complications because of their underlying medical problems. Additionally, women who had a history of thromboembolism or stroke were also eligible to participate on the trial. And so therefore, they also were perhaps at slightly increased risk. Well, the results of the WHI really showed that for the combination arm, breast cancer, coronary heart disease, pulmonary embolism had increased risks. There were decreased risks of colon cancer and hip fractures. And for estrogen, only increased risk of stroke, which really was between years 2 to 5 of usage, decreased risk of hip fracture, and no effect on coronary heart disease. This just shows the difference, a hazard ratio of 1.29 for the estrogen and progesterone, showing the increased risk. And when we start to look at the breast cancer, we see that the hazard ratio for invasive breast cancer is 1.26. So there were 166 cases of breast cancer in the EP arm, where the placebo had 124. No increased incidence of endometrial cancer, actually decreased risk of colorectal cancer, and pretty much for the EP group, slightly increased risk of all cancers. Well, what if we look at those women who actually develop breast cancer on the WHI study? The first thing we find is that there was really no difference with regards to race or ethnicity. We find that if you had never used hormone replacement therapy previously, you had a lower rate of developing breast cancer compared to the placebo group during the initial 2 years of your usage. Your third year, you pretty much equaled the placebo group, and then you started to increase. So it actually suggests that there's some type of an exposure issue going on. For patients who had received HRT previously, we find that the incidence of breast cancer was greatest in the third year, and then continued to increase beyond that. So again, prior exposure, increased risk, it started up earlier. What we see is that the invasive breast cancers for the women on the study were actually larger, node positive, and more of an advanced stage, which you need to start to question why. These were women who were being very heavily screened. They underwent regular mammography. They had to have a baseline mammography to enter the trial. So why is it that this group of women are actually having a higher incidence of disease? Was it that they were developing cancers that were more difficult to detect? Lobular tumors tend to be a little bit more difficult to detect on mammography than ductal carcinomas. That didn't pan out. So it doesn't really explain what had happened either. During the first year of therapy, there was a greater incidence of abnormal mammograms on the EP arm. And one of the things that became very obvious is that breast cancer density increased. And we know that with hormone replacement therapy, it actually prevents that normal physiologic change that happens during menopause, where breasts have more fatty infiltration. And there's a decrease in epithelial cells that are seen. And with hormone replacement therapy and the density increasing on the breast, we actually know that there is an increased risk of developing breast cancer. And the other thing that's interesting is that there was no difference between the placebo arm or the HRT arm with regards to whether or not the patients developed ERPR tumors or the histologies that were seen. Well, we know that mammographic density is associated with an increased risk of breast cancer. First of all, the detection of malignancy is compromised. Dense breasts are much more difficult to detect tumors. We know that from young women. Many times it's impossible to find it. And if you have, there's a 4 to 6-fold increased risk of breast cancer for women who have dense breasts that are more than dense tissue in 75% or more of the breast. Now, one of the things that they also realize is that genetic variations in different enzymes that metabolize estrogen and progesterone can be associated with increased mammographic density. And so therefore, there's probably innate differences between women that lead or predispose them to these changes. With the WHI program, there was a 6% mammogram density increase for the first year of estrogen and progesterone therapy compared to the placebo group. So what are the criticisms of the WHI? Well, first of all, the population that were enrolled had previously received HRT. Many times they had gone through menopause years before, so there was a delayed initiation of HRT. They had sometimes received hormonal therapy, some had not. And they were a population at risk for coronary artery disease and cerebral arteriosclerosis. There's also been discussion that perhaps the regimen that was chosen, the conjugated equine estrogen and the medroxyprogesterone acetate, was not the proper choice, and that the progestational agent actually negated the positive effects of estrogen. The regimen was previously untested. There had been benefits shown with estrogen and cyclic progesterone. This was daily progestational treatment. So perhaps that was part of the issue. And the other question that actually gets raised is, was this the appropriate study design? Or was this a trial that was actually done to reflect the general population of women, and women who were at risk were placed on the study who should not have been? Well, at the same time or shortly thereafter, the WHI, the Wisdom trial, got initiated in England. It was closed prematurely as soon as the WHI results came out, but pretty much similar findings. There was a significant increase in cardiovascular events and venous thromboembolism, and the conclusion of the lead investigator of the trial was that the long-term benefits and risks of HRT in women who start therapy for menopause and for symptom control have been unanswered. And I think that's one of the key issues. Most of us now use HRT for women who are symptomatic with vasomotor symptoms, and that's being done, initiated right after they start to go through menopause. This was a much different group. This was a group of women who had actually been through menopause years before. So are we trying to compare apples and oranges, or did we take a group of women who are much different than the group of women we're going to treat with HRT now? So before we continue, I'm just kind of curious, when does this group of physicians prescribe HRT to your patients? I never prescribe hormone replacement therapy to my patients. I only prescribe hormone replacement therapy when my patients have hot flashes. I don't believe the results of the WHI study and still prescribe hormone replacement therapy. And I select patients who I think would benefit the most from hormone replacement therapy and use it for a set period of time. 50-50. 50-50. I never prescribed hormone replacement therapy, and I select patients who would benefit most from the therapy and use it for a set period of time. And I think that pretty much that's what most of us would say. All right, so what do we know? First of all, if we look at the results of all the studies, we know that hormone therapy is very effective in relieving menopausal symptoms. There really is no effect on cardiovascular or coronary heart disease. We know that observational studies have shown benefits, but none of the randomized trials have. We know that there's an increased risk of breast cancer, stroke, and clots that are not offset by reductions in the risk of hip fractures. And we know that the risk of breast cancer is increased. So this really led the FDA and many other international agencies to say that hormone therapy is really only indicated for moderate to severe menopausal symptoms. It should not be used for the prevention of cardiovascular disease or dementia. It can be used as an option for prevention of osteoporosis. That's the FDA standing. However, if you go to the European agencies and look at their mandates, they would actually disagree with that statement, that you need to carefully consider the risks and benefits. You need to use it at the lowest effective dose for the shortest duration possible. And every 3 to 6 months, you need to review whether or not your patient should remain on that therapy and make adjustments as needed. Well, what's happened? Pretty much after the WHI results were released, women stopped using HRT and sales plummeted. And what really happened is after that, WHI was released in 2002. Up to 2002, there was an increased incidence of breast cancer seen yearly. And from 2002 to 2003, there was, for the first time, a decline noted. And it actually was 6.7%, so something that you can't ignore. The reductions were seen in women who were 40 to 50 years of age and older. And it was really attributed to the falling use of hormone replacement therapy. And the other thing was seen that there was a decline in the number of ER-positive tumors. Now that was using SEER data. But if we look at the Kaiser study, which actually is wonderfully set up to do epidemiological research, they found that the rates of breast cancer for women 40 years old were stable, but that for women who were older, the rates had been increasing up to 2001, first due to the increased use of mammograms in the 1980s, and then due to HRT in the 90s. But then after 2003 to 2006, the rates started to drop. And in epidemiological studies, that decline from 2003 to 2004 remained stable, and it has pretty much since that time. So breast cancer incidence rates, when we look across race and ethnicity, we really found that HRT use, if we attributed declines in the incidence of breast cancer, did not affect the women who were Black, non-Hispanic, Asian Pacific Islanders, or Hispanic patients. Those are going to be a group of women who probably use HRT less than Caucasian patients. So if it was truly not due to HRT, we would have expected to see across the board of all races and ethnicities a subsequent drop in breast cancer risk, which was not seen. So if we all look at this picture, regardless of what our subspecialty is, despite the fact that there's the big red bullseye around the breast cancer, we could all pretty much figure out that's breast cancer on a mammogram. And if we look at it, we're probably thinking in our head that's breast cancer. Some of us may be more sophisticated and sitting there saying, is that lobular or ductal carcinoma? What is that? But it's breast cancer. The thing is that what we know now is that breast cancer is not one disease. And our understanding of breast cancer since 2002 has actually progressed significantly. This is actually a picture of a tissue microarray. And this represents the seminal work that was done by Torres Sorley, Chuck Perot, and the Bostein lab, looking at whether or not we could identify genetic differences between different types of breast cancer. This is the tissue microarray here, which is quite complex. Notices that the colors in green are actually genes that are downregulated. Colors in red, they're upregulated. And what they found is that when you look at these tissue microarrays and look at the different types of breast cancer, we find that there are marked genetic differences in breast cancers, and they come out into 5 clusters. Basal-like, represented in red, HER2, overactive, luminal A, and luminal B. And these molecular portraits actually have profound implications in terms of outcomes and risk. So if we look at the tissue microarray and then look at good signature and poor signatures basically being the basal cell or basal tumors, we can find that patients can actually it can be determined at the time of diagnosis whether or not somebody has a poor or a good prognosis. So breast cancer has gone from just a spot on a mammogram down to the tissue level now where we can actually determine these differences. Just to kind of further look at the heterogeneity of different breast cancers, the luminal A and luminal Bs are usually the good prognosis tumors. Those are the ER, PR positive, sometimes HER2 positive, which have a better prognosis. The HER2 overexpressing are ER, PR negative, and HER2 negative, positive, sorry. And the basal-like, which is called the dreaded triple negative, is ER, PR, and HER2 negative. And the triple negative, or the basal-like cancers, are the ones that fortunately don't comprise the majority of tumors. They only comprise about 15% of all breast cancers. They're seen in a higher proportion in young African American women and patients who are BRCA1 carriers. They're high grade, poor prognosis, highly proliferative, despite the fact that they're very chemosensitive and often respond initially to chemotherapy. They have a very high risk of early and distant relapse. And so the majority of these women will have metastatic disease or recurrences and will die from their cancers. So now when your patient is diagnosed with breast cancer, their tumor's actually typed from their paraffin-embedded tissue by doing what's called an Oncotype 21 gene assay. And what this assay does is it looks at 21 genes, 5 reference genes, and these 16 other genetic mutations that are characterized by proliferation, invasion, estrogen-type genes. And based upon this formula you see on the right, then is determined a risk score, and your patient is placed into a low risk, intermediate risk, or high risk category, and further or subsequent treatment is based upon that. So it's gone from, if you have an ER/PR positive tumor, you're going to get placed on hormonal therapy. If you're young, you're going to get chemotherapy. If you're old, you're not. To oncotyping and then determining what your risk of recurrence is, and then basing your further treatment and therapy there. And you can really say that breast cancer has moved closer to that whole personal or molecular profiling and personalized medicine that we've been able to achieve in GYN oncology. So we know that prognostic indicators for breast cancer are the size of the tumor, lymph node status, histologic grade, type, estrogen and progesterone receptor positivity, HER2 status, p53 mutations. P53 is often associated with poor prognosis, Ki-67, which is a proliferation index, and genomic profiling. So now where are we at? So we have a much better understanding of breast cancer than we did previously. We still have the results of the WHI, and I think there are really 4 questions that we have to answer. The first is, why did the breast cancer incidence drop as quickly as it did? Can it really be attributed to the fact that HRT usage dropped? And that's going to be the first question. So we already established that starting in 2003, breast cancer incidence decreased by 6.7%, especially in the women who are older, ER-positive tumors. So we have to come up with possible explanations. So the first one we have to look at, was there a change in screening mammography? Did the number of women getting mammograms drop? And the answer is no. We can't attribute it to that. And besides, if that were the case, we would expect it to fall across all groups. The next thing is, are tumors detected by mammography more likely ER positive? Well, no, they're not. They're more likely ER negative, because the ER positive tumors are usually more luminal tumors, which we saw from before. They're more plaque-like, flat. They don't make a nice mass on mammogram. They're much more difficult to detect. So that can't be the answer for that. So then the other answer is, there is definitely a direct hormonal effect by HRT. And studies have actually showed that there's a decrease in the proliferative index after 1 month of discontinuing HRT usage, and that even if you did use HRT, by 5 years after stopping your usage, your risk or your elevated risks drops. So if we think about it, well, breast cancers take a long time to develop. We know that the doubling time of a tumor is between 25 to 129 days. It takes about 30 to 35 doublings to actually make a tumor that's 5 to 10 millimeters. That takes about 5 to 10 years to diagnose a breast cancer. So why do we see this drop so quickly? So what we actually understand now is that HRT probably acts as a promoter, and through combining with other factors, stimulates growth of well-differentiated tumors that were already present, that were slow growing. And so it's not causing a direct transformation of normal cells into malignant cells, but actually is probably stimulating growth of cancer cells that were already there. So Prasad actually did a very neat little study. He's a breast surgeon out of, I believe, Mass General. And what he did was he took women who were about to undergo lumpectomy or mastectomy. He took their pre-op core needle biopsies and then took their final tumor specimens at the time of their definitive surgical procedure. And what he looked for was changes in the molecular signature of the two tumors between the time when they were on hormone replacement therapy and the time they had their surgery. Now, as you can imagine, the majority of women actually stopped using hormone replacement therapy. Few patients kept using it. And what he was able to see was compare the patients from their pre-op biopsy to the end. And in this very short period of time, the mean number of days to surgery was approximately 17, ranged from 2 to 31 days. So we're talking 1 month change in time. He actually found a decrease in Ki-67, which is a marker of proliferation, decrease in the progesterone receptor expression, which is influenced by estrogen, decrease in cyclin D1, and an increase in P27, which actually controls cyclin kinases. And all of these findings only occurred in the ER-positive tumors. And so therefore, even a 2 to 4 week discontinuation of HRT actually causes molecular changes in breast cancers that are pretty immediate. And so therefore, we can assume that maybe stopping HRT did drop breast cancer risk as quickly as it did in 2003. So looking at the biologic plausibility of the rapid decline, we know that HRT already fuels the expansion of previously existing breast tumors. It acts as a promoter, and we're increasing breast density, we already know that that increases the risk of breast cancer. So I think the next question is, are there even more subtle genetic or molecular risk factors that increase a woman's risk of developing breast cancer of using HRT? We know that there are differences. Women who have higher concentrations of sex hormones actually will have an increased risk of developing breast cancer. Genetic variabilities in metabolism of steroid hormones, drug transport, sex hormones, regulation of cell cycle, and cytokines all can be associated with increased risk. We also know that HRT could potentially reactivate cancer stem cells. This is a new area of work. We know that circulating tumor cells in breast cancer has been associated with increased risk of recurrences. If women are treated with breast cancer and they still have a high percentage of circulating tumor cells at the completion of treatment, they're going to recur in a very short period of time. And what we realize is that the progestational agent actually reactivates these stem cells and causes a reservoir of breast cancer cells to develop into tumors. And so that could be a possible explanation for why women who had no evidence of breast cancer then go on to develop breast cancer when using HRT because of these stem cells. So does breast cancer that develops in a woman on HRT behave differently? Well, it probably does. And so if we look at the Million Women study, again, there was an increased risk that associated breast cancer risk, and after the cessation of HRT, that risk declined, and at 5 years, there was no increased risk. There were increased risk across the board for histological subtypes, but there was really no significant difference in trends or relative risk with duration of use. But one thing that the Million Women study actually found that was pretty significant was the association with BMI. And so if we look across the board, pretty much just for ductal and lobular carcinomas, and we look at BMIs of 25 to 29, and greater than 30 kilograms per meter squared, what we really find is that those women who are thinner or have a lower BMI are at greater risk for developing a tumor than women who are overweight. Okay, so we can see that if we look at our thin menopausal patient and place her on HRT, the woman who's going to be more likely to have those vasomotor symptoms, they're going to be at an increased risk. And we can see relative risks of 2.28 for ductal carcinoma for the EP group, 3.46 in the lobular carcinoma in the EP group, and 4.39 in the tubular carcinomas. And so the risk not only is greater in the thinner woman, but it's also greater with the progestational use. So we can start to think about, well, can we, in a more global fashion, just look at BMI as a risk factor when we're counseling our patients regarding HRT use? We also know that for patients who have early stage breast cancer, that HRT does affect their recurrence. And this was a cohort study looking at 5-year recurrence risk for women who had used HRT and had been diagnosed with an early stage breast cancer. 14% of women had disease recurrence, which for somebody who has an early stage cancer probably is a little elevated, but not that horrible. 27% are local, which means that they can be salvaged, but 50% were distant, which means that they cannot. They found that there was an increased risk of recurrence if you were diagnosed before 1995 and you were premenopausal, but that HRT was associated with a decreased risk of recurrence. Kind of different than you think about it. When WHI, we noticed that the tumors were larger, they were more likely node positive. That's why this discrepancy. Well, we have to go back again to breast cancer heterogeneity. And Kwan pretty much tried to look at this thinking, are there individual lifestyle factors that can impact or affect our breast cancer risk in our patients, moving beyond just HRT? And so she looked at over 2,000 breast cancers and subtyped them. She then looked at demographic, reproductive, and lifestyle information. And she tried to determine whether or not these modifiable lifestyle factors could be attributed with the development of a specific tumor subtype or tumor type. And she primarily looked at obesity, breastfeeding, and alcohol consumption. So what she found was the luminal type B cases, so those are usually the ER, PR, sometimes HER2 positive, were younger at diagnosis, less likely to consume alcohol, less likely to use HRT, less likely to use oral contraceptives. The triple negative cases, which are the very poor prognosis cases, were younger, African American, didn't breastfeed, more likely to be overweight or obese. And for the premenopausal HER2 overexpressing cancers, they were younger at diagnosis, Hispanic or Asian, and less likely to use HRT. So we can already see that moving beyond molecular profiling, we can also find lifestyle factors that are impacting upon the diagnosis of breast cancer in our patients. So I think the last question is, can HRT be modified or our patient's behavior be changed in a way that benefit can be seen with HRT use? So now we have transdermal estrogen. We know that oral estrogens through the increasing of angiotensinogen can lead or may lead to an increased hypertension, whereas transdermal estrogen has actually been shown to decrease blood pressure. We know that HRT decreases obesity, insulin resistance, onset of diabetes, so changes in metabolic syndrome. We can see changes in clotting factors, cholesterol levels, and atherosclerotic plaques. Well, the KEEPS trial was initiated in 2005 because realizing the limitations of the WHI that we actually just outlined previously, they thought that they could do it better. And so they're looking at a 5-year clinical trial using conjugated equine estrogens versus transdermal estradiol, much lower dosages, and combining that with micronized progesterone. So women are being enrolled immediately after menopause, and they're trying to determine whether or not there's differences that are due to changes with regards to clotting factors, increase of C-reactive protein, atherosclerotic lesions. And building upon animal studies that have actually shown that there's this window of opportunity where initiating hormone replacement therapy immediately after menopause actually will decrease atherosclerosis by 50 to 75%. And the endpoints of this study, as compared to the prior studies, is looking at intimal medial thickness of the carotid arteries and also coronary calcium buildup. Well, the first thing is that we don't have the results of KEEPS yet, but that a couple of things have been found. First of all is that the conventional risk factor profiling by the Framingham risk score didn't predict the presence of premature atherosclerosis. So it really shows that we're treating women who are at risk that we don't recognize or realize that risk. They also found that differences in enzymes involved in metabolism of steroid hormones can increase cancer risk, that there was actually impaired glucose tolerance of approximately 15% that would not have been picked up with a fasting glucose level, and that 15% of women had quantifiable vascular lesions. And that in a subset of women without lesions, that standard algorithms used to detect risk would not be effective. So if we look at our risk factors, we can't do anything about female gender. We can't do anything about advanced age. We can't change family history or reproductive history. Can't do much about genetic mutations. But we can do something about obesity, physical inactivity, alcohol consumption, hormone exposure, and work. So Sprague actually looked at modifying lifestyle and decreasing breast cancer risk. And what they tried to establish was whether or not risk factors had been modified, would patients have gone on to develop breast cancer. It was part of the collaborative breast cancer study, and women between the ages of 20 to 69 were matched with controls. And what they really found was that 40% of postmenopausal invasive breast cancer could be eliminated if women did not use hormones. They restricted alcohol consumption to less than 1 drink per week. They avoided weight gain of more than 5 kilograms after the age of 18, which is not easy to do. And they exercised more than 5 hours per week. And I don't know about you, but that for me is virtually impossible. But those are things that actually can be done to decrease risk. So at the end of all of this, where are we at? I think I'm as confused now as I was at the beginning, because I really don't think we understand what happened, what went on, or why we had the findings. I'm hoping that the KEEPS trial, when those results are published, will actually help us answer some of the questions that we have. I think that our understanding of breast cancer has progressed significantly and is going to further develop, and will probably help us answer some of these questions further in the future. So what I'd like to ask now is the same question again. So will you prescribe HRT to your patients? I will never prescribe HRT to my patients. I will only prescribe them when they have hot flashes. I still don't believe anything you talked about for the last 45 minutes. Or I will select patients who I think would benefit and use HRT for a set period of time. So those are your 4 choices. Wow. So you guys went from being split to I will select HRT and use it for a set period of time. So I guess we did somewhat change your practice patterns. I think we can compare. But anyway, thank you very much.